Thank you, Dr. Nikki Stamp, for teaching general surgeons the latest about cardiothoracic surgery.
My pleasure.
A couple of questions. The status of the LVAD is
Mm.
is the left ventricular assistance device a destination therapy now?
Yeah, I think it's going to be eventually. There are some patients who are on LVADs for destination therapy. So I guess just a quick rundown. LVAD, or it comes under the larger umbrella of mechanical circulatory support for the failing heart, and it's really revolutionized what we do with transplant. So before these were around, if you needed a heart, you just had to wait with bad symptoms and basically not surviving potentially to getting a transplant. But these have made a huge difference in our ability to optimize these patients to transplant. They have better quality of life. They're actually able to walk to the bathroom, or really helps their failure symptoms. And the newer devices, which are onto the third generation now, it's just a massive improvement. So when I first started cardiac surgery, we were using devices about this big. They were huge and they were clunky, and they couldn't actually fit in most patients, or a number of patients. So for me, I'm 5'6". I'm or 5'7" at a pinch. Those devices probably would have been too big for me if I needed an LVAD. So now we're into fantastic devices, and they've really come along in leaps and bounds. And because how good they are and mechanically reliable they are now, they are really starting to move towards perhaps being the alternative to organ transplantation. So destination therapy would be the first port of call. So the three ways that we would normally use it would be bridge to transplant, someone waiting for a heart; bridge to recovery, so that hopefully their heart muscle would recover and we could explant the LVAD; or this sort of third group, the destination therapy. At the moment, destination therapy is generally used for patients who for some reason wouldn't quite qualify for a transplant. The criteria for needing both are very similar. There's certain the appropriate problem, the appropriate physiology that's going to respond to the device. But the destination therapy are people who may not qualify for a transplant because of comorbidities, malignancy, previous malignancy, so a number of things. In this country, if you need a destination VAD, you have to pay for it yourself. It's not covered by any medical insurance, because it's not. Yeah, it's not essentially approved for this at the moment, but that will probably change. And I think one of the big things that's going to change for destination therapy for VADs is going to be as the devices improve. So at the moment, they're driven by a power pack that the patients wear on their waist or over their shoulder, through a drive line which enters and exits through the abdomen. And that's quite a big limitation. They are very prone to infection. So the ideal thing would be to have transcutaneous charging technology. So it's completely internal device. The devices are getting smaller. All of these things are going to add up to potentially one day, maybe not in the near future, but potentially one day, surpassing essentially heart transplants, which is excellent.
Oh wow, yeah, and these have become common enough now that we see patients coming in with appendicitis and gallbladder problems.
Yeah,
So what is it that a general surgeon has to keep in mind now when someone with an LVAD comes in and needs their gallbladder out? Just in terms of things like thromboembolism prophylaxis and taking them off what they're on.
Yeah, okay. So we have the same problem, to be honest. I've done lobectomies on patients who have developed lung cancer while they're on their VADs, and they sometimes need valvular heart disease. So we're all in the same boat here. It's a kind of it's a big coordinated effort that we require to appropriately look after these patients. So I think the first thing to know is that they are anticoagulated, and they're often on triple therapy, which is warfarin, aspirin and clopidogrel. So they're pretty easy. And It's not, it's like a surgeon's worst nightmare, isn't it? But so the first thing is that can be stopped for a period of time. There is the thrombosis risk, and that thrombosis risk is a little different depending on which device. The other thing I think is really important is that I'm not sure what it's like in the States, but we wouldn't do anything to these patients out of a centre that manages their LVAD. And that's really what it comes down to. You need the team. So you need the cardiologists, the cardiac surgeons. I think it's reasonable to have you really should have a cardiac anaesthetist to anaesthetise the patient. The use of transesophageal echo throughout their surgery to look at their volume status, because the VAD is very, very volume dependent. If they're too dry, it sucks flat and won't give any forward flow. So those kinds of things are very, very important to be done by a specialist team.
So you're not just giving them an LVAD and sending them to the bush to live 2 days away from a center?
We send them reasonably far afield here. As you know, we're pretty sparsely populated in Australia. They don't venture too far afoot. But any problems, they do usually come straight back to the referral centre, the VAD centre, okay. And that's really where they should be. I mean, I know if I weren't familiar with a VAD, I wouldn't want. I'd be very nervous about looking after a patient with one. There is a lot of finesse to it, so
that must be a criterion then when you think about giving someone an LVAD is where they live and how far they're going to be from.
Yeah, it depends. Yeah, they are. Like I say, in Australia, we're very spread out. And I think earlier on in programs, we made people basically stay in major cities so that they were close. And now they're sort of going a little bit further afoot. Even patients who are waited for transplants, and I'm sure it's the same for other solid organ transplants, that they do, we do have to know how we're going to get them from A to B, in the event an organ becomes available. So it creates a logistical problem. But I think the other thing is that, patients, they've got to live. We're doing this for quality of life in some regards, and having them, pack up and move everything isn't always the best thing for the patient, but they do need to be able to get to medical care. And I guess things like what we're doing now, Skype and telemedicine, has kind of revolutionized the way we can to look after these patients from a bigger distance than what we may have done in the past. But sorry, go on.
if a patient with an LVAD were to come in and I couldn't get them to a center, and how are they managed differently from other CHF patients from the standpoint of volume?
So volume's quite hard to manage based on clinical criteria, more so than your average patient. They're probably tolerant of volume more than your average heart failure patient. Now they actually have some forward flow, but they're very intolerant of hypovolemia. That's one important thing. Most places have access to cardiology who can perform even a transthoracic echo to be able to see how the VAD's functioning, what the heart, how full the heart is, and things like that. I think very early referral to a cardiologist. The other thing is that we're always on the end of the phone. There's always that advice on the end of the phone to be able to guide people. And I think early referral, even if you're a while away, early referral to a VAD centre, discussion with a VAD centre is vital. Management of anticoagulation is another thing that would have to definitely needs to be referred on. We will stop it obviously for procedures, and it'd be nice to do them in an elective fashion, but as you point out, they get appendicitis and cholecystitis and all these other things that happen to anybody else in the community. But you can stop the anticoagulation and then bridge them with IV heparin until they're fully re-anticoagulated.
And are LVAD patients on antibiotics all the time or no?
Not all the time, no. They need sort of standard prophylaxis that we would use, perioperatively. Obviously for bowel surgery, you're going to cover them slightly different things to what we might use, but they should have the standard prophylaxis. A lot of patients do have driveline infections. It's a relatively not common, but it's a frequent complication of the LVADs. They may be on antibiotic therapy or dressings for that, but they're not normally on across the board prophylactic antibiotics.
Gotcha. Okay. So what else does a general surgeon need to know about them besides call somebody?
Call somebody. I think that is the key thing.
That's the key thing.
And how to manage the anticoagulation. I guess the other thing is that the probably might actually be relevant to a general surgeon is some of the bigger devices on the market, and there's one called HeartMate 2, and it sits in a preperitoneal pocket, which means it can become intraperitoneal from time to time. So just keep an eye out, I guess. If you see something...
You see something unfamiliar next to the gallbladder.
That's right. Should be the bad.
Good tip. Okay.
Yeah.
All right. Well, thanks so much for running us through LVADs. Appreciate your input.
My
I hope
pleasure.
to talk to you again soon.
That's great. Thanks so much.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.